welcome to the Deep Dive. Today we're getting into something really specific but critically important. Abdominal aortic aneurysms, or AAAs.
That's right.
Our goal here is to really unpack the latest thinking, drawing from the Society for Vascular Surgery's Comprehensive Practice Guidelines. We want to cut through the complexity and give you the core knowledge you need.
Exactly. These guidelines are, well, they're dense, packed with detail. But we're going to pull out the most crucial, actionable insights for you. Think of it as translating the expert consensus into what matters for understanding and managing these conditions.
Okay, perfect. So let's start right at the beginning. What exactly is an abdominal aortic aneurysm?
Fundamentally, it's an enlargement, a dilation of the abdominal aorta. The specific definition we use is 3.0 centimeters in diameter or greater.
And just to orient everyone, the abdominal aorta, that's the main artery running down through the abdomen, right?
Precisely. It typically starts just below the diaphragm, around the level of the 12th thoracic vertebra, sits in the retroperitoneum, so behind the main abdominal cavity, and then it usually divides into the common iliac arteries, roughly around the level of the umbilicus of their belly button.
Okay.
But an important point here is that the aorta naturally tends to elongate and widen a bit as we age.
Oh.
So if you're doing a physical exam and feel a pulsatile mass, its exact location can actually vary quite a bit because of this natural change over time.
That makes sense. So how reliable is that physical exam for actually finding AAA?
Well, that's the challenge. The physical exam actually only has moderate sensitivity for detecting AAAs. It can pick some up, sure, but it misses a fair number too. Which is why there's a strong recommendation. This is a grade 1A recommendation, meaning high-quality evidence supports it to assess the femoral and popliteal arteries, those in the groin and behind the knee, in patients where you suspect or already know they have an AAA. And vice versa. If you find an aneurysm in the leg arteries, you absolutely need to check the aorta. They often go hand in hand.
So to quickly recap this first bit, an AAA is the aorta widening to 3 centimeters or more. Physical exam is helpful, but not definitive, due to moderate sensitivity and age-related changes. And critically, always check the peripheral arteries if you suspect an AAA, and check the aorta if you find peripheral aneurysms. That's a grade 1A.
Exactly. Now, let's try a quick clinical thought exercise. Imagine a 68-year-old man, routine physical. You palpate what feels like a subtle pulsatile mass in his abdomen. Given the limitations we just talked about, what's your immediate next move?
Based on what you said, relying just on the feel isn't enough. You'd need imaging, right? Probably an ultrasound.
Precisely. The most appropriate step is to recommend a one-time ultrasound screening. The pulsatile mass is suggestive, yes, but ultrasound is the non-invasive gold standard to confirm presence and size, especially in a man this age, possibly with a smoking history, where screening carries that grade 1A recommendation.
Okay, that makes perfect sense. Which leads us straight into the next big question. Who actually gets these? What are the key risk factors?
Right. This is crucial for understanding who we need to be most vigilant about. And the data is pretty clear on the major players.
So what's top of the list?
Age. Without a doubt, age is the single most significant risk factor. The odds ratio climbs dramatically as people get older, especially between 65 and 79 years old. We're talking up to maybe 14, 15 times the risk compared to younger individuals.
Wow, that's substantial.
It really is. And gender plays a big role, too. AAAs are much more common in men. The odds ratio is around 5.7, so men are nearly 6 times more likely than women to develop one.
Okay, age and male gender. What about lifestyle factors? I imagine smoking is high on the list.
You imagine correctly. The link between cigarette smoking and aneurysmal disease is, well, it's profound. Over 90% of patients who present with an AAA have a history of smoking.
Over 90%.
Yes. And it's strongly dose-dependent. Even relatively light smoking, say, less than half a pack a day for up to 10 years, more than doubles the risk.
Okay.
But heavy, long-term smoking, more than a pack a day for over 35 years. That's associated with a 12-fold increased risk. It's estimated that each year a person smokes increases their relative risk by about 4%.
That's staggering. And does smoking affect existing aneurysms too?
Absolutely. For individuals who already have a small aneurysm, continued smoking significantly accelerates its growth rate by about 35% faster compared to non-smokers.
It really paints a picture of just how damaging smoking is to the aorta.
It does, and there's a fascinating public health correlation here. Over the last few decades in the U.S., as per capita cigarette consumption has steadily declined.
Yeah.
We've seen a parallel decline, more than 50% in the last 20 years, in deaths from ruptured AAAs.
That's a powerful link.
It is. Now, part of that decrease is also due to better surgical outcomes, wider screening, and improved cardiovascular disease management overall. But the drop in smoking is clearly a major contributor. Conversely, in places where smoking rates remain high, AAA mortality is unfortunately still increasing.
What about things like e-cigarettes? Is the risk known there?
That's still an area of active research. The long-term risks aren't fully clear yet, but there is concern that nicotine exposure itself, even without the combustion products of traditional cigarettes, might promote AAA development. So it's definitely not risk-free.
Okay. So beyond age, male gender, and this huge impact from smoking, what else increases risk?
Other significant factors include high blood pressure or hypertension. Having concomitant peripheral arterial disease or cerebrovascular disease also increases risk. And a family history of AAA is another important one.
Are there any factors that surprisingly decrease the risk?
Yes, and this is quite interesting. Diabetes mellitus is consistently associated with a reduced risk of developing in AAA.
Really? Diabetes usually increases vascular risk.
It does for occlusive disease, but not for aneurysmal disease. The mechanism isn't perfectly understood, but it's a consistent finding. Also, perhaps less surprisingly, smoking cessation significantly reduces risk. Quitting for more than 10 years can cut the risk by nearly 60% compared to current smokers.
That's a huge benefit.
It is. And a healthy lifestyle, specifically eating fruits and vegetables, getting regular exercise, is also protective. Interestingly, increased salt intake has been linked to increased risk in some studies.
Okay, so that covers developing in AAA. What about the risk of it rupturing? Are the factors different?
They overlap, but there are some key factors specifically associated with higher rupture risk. Rupture risk is notably higher in women compared to men for aneurysms of the same size.
That's important.
Very. Current smoking is also a major driver of rupture risk, roughly doubling the hazard, and elevated blood pressure is another key factor.
And what about the size itself? How does that play into rupture risk?
Size is obviously critical. The larger the aneurysm, the higher the risk. While older studies suggested very high rupture rates, more recent pooled analyses give us slightly lower, perhaps more accurate figures. For AAAs between 5.5 and 7.0 centimeters, the annual rupture risk might be around 5.3% per year.
Okay.
And for those over 7.0 centimeters, it's a bit higher, maybe around 6.3% per year. Still significant, but perhaps not quite as high as previously thought for some size ranges.
Right. So let's quickly recap these risk factors. Age and male gender are the major non-modifiable risks. Smoking is incredibly impactful, dose-dependent, accelerates growth, and its decline correlates with fewer rupture deaths. Hypertension, other vascular disease, and family history add risk. Protective factors include diabetes, smoking cessation, a big one, and a healthy lifestyle. For rupture specifically, female gender, current smoking, and high blood pressure are key concerns, alongside aneurysm size itself.
Excellent summary. Now, another quick scenario for you. Consider a 70-year-old woman. She has a significant smoking history, hypertension that's well controlled, and type 2 diabetes. She presents with new abdominal pain. Her last AAA screening 2 years ago was negative. Based on her profile, which factor carries the highest odds ratio for AAA development, and which one actually offers a protective effect against it?
Okay. Smoking is obviously very bad. Hypertension adds risk. But you said age was the biggest single factor, right? So I guess age has the highest odds ratio here. And the protective one. And a surprising finding about diabetes.
Exactly right. While smoking is extremely detrimental, in terms of sheer odds ratio for developing in AAA in this age group, age itself is paramount. And yes, despite her other vascular risks, her type 2 diabetes is associated with a reduced likelihood of having a AAA compared to someone without diabetes.
Fascinating. Okay, so we know who's at risk. How do we actually find these aneurysms, and then how do we monitor them? Let's talk screening, surveillance, and imaging.
Right. Given the risks, especially in certain groups, screening becomes very important. And the evidence strongly supports ultrasound for this.
So who should be screened?
The strongest recommendation, again, grade 1A, high-quality evidence, is for a one-time ultrasound screening for AAA in both men and women aged 65 to 75 who have any history of tobacco use.
Both men and women now. That's relatively recent, isn't it?
It reflects evolving evidence, yes. Previously, the strongest recommendation was primarily for men. Now it includes women with a smoking history in that age range, too. There's also a suggestion, this is grade 2C, so lower quality evidence, but still potentially beneficial for screening first-degree relatives, like a parent or sibling, of patients within AAA if those relatives are between 65 and 75, or even older if they're generally healthy.
What kind of impact has screening actually had? Is there proof it saves lives?
Oh, yes. The Multi-Center Aneurysm Screening Study, or MASS trial, was a landmark study. It followed men for over 13 years and found a 42% reduction in AAA-related mortality among those who were screened compared to those who weren't.
42% reduction, that's huge.
It is. They estimated that screening about 216 men prevented one AAA-related death, so the benefit is clear. However, there are still challenges in implementation. For example, data shows about 40% of AAA repairs in Medicare patients happen after the aneurysm has reached a size where elective repair is usually recommended, suggesting many screening opportunities are being missed.
So screening works, but we need to do it more consistently.
Yeah.
Now, once an aneurysm is found, how do we watch it? What imaging do we use and how often?
Good question. While ultrasound is great for initial screening, finding out if an aneurysm is there, computed tomography or CT scans are generally considered more reproducible for measuring the exact size.
More precise measurements with CT.
Yes, studies show over 90% of CT measurements are repeatable within about 2 millimeters. Ultrasound can be a bit more variable depending on the operator and patient factors. It's also worth noting that CT measurements often appear slightly larger, maybe 2 millimeters larger, than ultrasound measurements.
Why is that?
It's mostly due to how the images are acquired. CT takes cross-sectional slices perpendicular to the vessel, which tends to give the maximum diameter, whereas ultrasound might measure slightly differently depending on the probe angle.
Okay, that's a useful clinical pearl. CT is more reproducible, potentially measures slightly larger.
Right. And beyond just diameter, research is looking at more sophisticated predictors of rupture risk, things like how fast the aneurysm is expanding, the stiffness or stress on the aneurysm wall, and even its specific shape, not just its width. But for routine surveillance currently, size is still the main guide.
So how often should we be doing these surveillance scans?
The guidelines suggest intervals based on the current size. For smaller aneurysms, say 3.0 to 3.9 centimeters, surveillance every 3 years is suggested. For medium ones, 4.0 to 4.9 centimeters, it's typically recommended yearly. And as they approach the threshold for considering repair, 5.0 to 5.4 centimeters, surveillance every 6 months is advised.
And the evidence level for those intervals?
These are all grade 2C recommendations. So based on lower quality evidence or expert consensus, but they provide a practical framework.
Okay. What about a patient who comes in with symptoms, maybe that sudden abdominal or back pain we mentioned earlier?
That's a different scenario, much more urgent. For a patient presenting with abdominal or back pain wherein AAA is suspected, ultrasound is still a good first step to quickly determine if one is present.
Quick look with ultrasound first.
Yes. But if an AAA is detected and the patient is stable enough, the strong recommendation, grade 1C, is to proceed to computed tomography aortography, or CTA, using intravenous contrast material, assuming there are no contraindications like severe kidney failure or allergy.
Why the CTA specifically?
The CTA gives us much more detail. It can definitively confirm or exclude rupture, which is the immediate life-threatening concern, and it provides the detailed anatomical map needed for operative planning, whether it's going to be open or endovascular repair.
Makes sense. But what if the patient isn't stable?
That's the crucial exception. If the patient shows signs of hemodynamic compromise, like low blood pressure, rapid heart rate, signs of shock, or if their condition starts to deteriorate rapidly, then all imaging studies should be abandoned immediately.
Forget the scans. Get to the OR.
Exactly. Time is critical. Care must be escalated immediately towards urgent operative intervention. Delaying for imaging in an unstable patient with a suspected rupture can be fatal. That urgency is reflected in the grade 1C recommendation for immediate escalation.
Okay, let's recap screening and surveillance. Strong grade 1A recommendation for one-time ultrasound screening in 65 to 75-year-olds with a smoking history, proven to reduce mortality. CT gives more precise measurements than ultrasound for surveillance, which is guided by size. 3 years for 3 to 3.9 centimeters, yearly for 4 to 4.9 centimeters, 6 months for 5 to 5.4 centimeters, all grade 2C. For symptomatic patients, rapid ultrasound, then CTA is key if stable, but immediate OR is unstable, grade 1C.
Perfect. Let's do another quick case. A 67-year-old man, former smoker, comes for his annual physical. He mentions his paternal uncle died from a ruptured AAA at age 62. He's asymptomatic, but asks if he should be checked. What's the single most appropriate recommendation for him right now?
Okay, he's 67, former smoker, and has a first-degree relative with a history of AAA who died from it. Based on the guidelines, the smoking history and age alone put him in the grade 1A category for a one-time ultrasound. The family history adds even more weight. So definitely a one-time ultrasound screen.
Absolutely spot on. The one-time ultrasound screening is the clear recommendation here, strongly supported by multiple factors in his history.
Great. So let's say the screening ultrasound or maybe surveillance imaging confirms in AAA that meets criteria for repair. How do you decide on the best treatment approach? This takes us to open versus endovascular repair.
Right. This is often the central decision point once an aneurysm reaches a size where the risk of rupture outweighs the risk of intervention, typically around 5.5 centimeters, though it can vary based on patient factors. The two main approaches are open surgical repair, OSR, and endovascular aneurysm repair, EVR.
Open surgery being the traditional approach.
Yes, involves a larger incision directly accessing the aorta, clamping it, and sewing in a synthetic graft to replace the aneurysmal section. EVR, on the other hand, is minimally invasive.
How does EVAR work?
With EVAR, we access arteries in the groin, usually through small punctures or incisions, and guide a stent graft, essentially a fabric tube supported by a metal scaffold up into the aorta under X-ray guidance. It's deployed across the aneurysm, effectively relining the aorta from the inside and excluding the aneurysm sac from blood flow.
Okay, so open versus minimally invasive. What do the big studies say about outcomes?
Several major randomized trials, like the EVAR-1 trial in the UK and the OVER trial in the US, compared the two head-to-head for elective repair. The consistent finding, supported by high-quality evidence, is a statistically significant short-term mortality benefit for EVAR.
Lower risk of dying soon after surgery with EVAR.
Exactly. Pooled data puts the 30-day mortality for EVAR at around 1.4% compared to about 4.2% for open surgery. So roughly a threefold lower risk of dying in that initial post-operative period with the endovascular approach.
That seems like a clear advantage for EVAR. But are there downsides or long-term differences?
Yes, there are important trade-offs. While EVAR wins on short-term mortality, it comes with a higher need for reinterventions over the long term.
Reinterventions, meaning more procedures later on.
Correct. Issues like endoleaks, which we'll discuss more later, or device migration might require further procedures down the line. Also, EVAR is associated with a slightly increased risk of late aneurysm rupture compared to open repair, where late rupture is extremely rare once a graft is sewn in place. These long-term considerations are also based on high-quality evidence.
So lower risk up front, but potentially more follow-up, and a small late rupture risk with EVAR. What about open surgery? Any variations there?
For open repair, one variation is the surgical approach. Besides the standard midline abdominal incision, there's the retroperitoneal approach coming in from the flank. Some meta-analyses suggest this approach might reduce blood loss, hospital stay, and intensive care unit time. But the evidence supporting this is generally considered lower quality. It's often preferred for more complex anatomy or certain patient conditions.
Does it matter where you get the surgery done or who does it?
It absolutely matters. There's clear evidence that outcomes are significantly better at high-volume hospitals for both elective and ruptured AAA repairs.
More experience leads to better results.
Yes. And surgeon specialty is also a key factor. Studies consistently show significantly lower mortality rates when the operation, whether open or endovascular, is performed by a board-certified vascular surgeon compared to, say, a general surgeon or a cardiac surgeon who might do these procedures less frequently. Subspecialty training and focus make a difference.
That's crucial for patients to know. Now, what about the most urgent situation, a ruptured aneurysm? Does the choice between open and EVAR change?
For a ruptured AAA, the situation is obviously much more critical. The recommendation, grade 1C, is that if the patient's anatomy is suitable for EVAR, then EVAR is generally recommended over open repair.
Even in a rupture, EVAR is preferred if possible. Why?
Well, some trials have shown similar 30-day mortality rates between EVAR and open repair for rupture. EVAR is less physiologically stressful. It avoids the large incision, potential massive blood loss during dissection, and aortic clamping associated with open surgery, which can be very taxing on an already unstable patient. It might also lead to shorter hospital stays.
Okay. And you mentioned timely intervention being critical for rupture.
Paramount. There's a good practice statement aiming for a door-to-intervention time from arrival at the hospital to the start of the repair procedure of less than 90 minutes. Every minute counts.
Less than 90 minutes.
So, and related to that urgency is the concept of permissive hypotension during the transfer of a patient with a suspected rupture.
Permissive hypotension. What's that?
It means consciously avoiding aggressive fluid resuscitation to try and bring the blood pressure back to normal levels before the bleeding is controlled surgically. The goal is to maintain just enough blood pressure to perfuse vital organs, typically a systolic pressure between 70 and 90 millimeters of mercury using limited fluids.
Why limit fluids? Wouldn't you want to replace the lost blood volume?
Counterintuitively, aggressively raising the blood pressure before the rupture state is secured can actually dislodge any temporary clot that might have formed and significantly worsen the hemorrhage. So the priority is rapid transport while maintaining that minimal target pressure, not normalizing the pressure en route.
That's a really important concept in managing ruptures. Okay, let's quickly summarize this treatment section. For elective repair, EVAR offers lower 30-day mortality, around 1.4% versus 4.2% for OSR, but requires more long-term follow-up, reinterventions, and has a higher late rupture risk. Open repair is durable, maybe benefits from a retroperitoneal approach in some cases. Outcomes are better at high-volume centers with vascular surgeons. For rupture, EVAR is preferred if anatomy allows, grade 1C, aiming for less than 90 minutes door-to intervention using permissive hypotension, systolic 70 to 90, during transfer.
Excellent summary. Let's apply this. A 60-year-old man arrives in the emergency department. Sudden, severe abdominal pain, looks shocky. Ultrasound confirms a large, ruptured AAA. Blood pressure is 70/45. You're prepping him for immediate transfer to a tertiary center capable of both EVAR and open repair. What is the most appropriate hemodynamic management strategy during that transfer?
Okay, ruptured AAA, unstable, low pressure. Based on what you just said, the key is permissive hypotension. Avoid aggressive fluids. So the goal would be to maintain that systolic pressure between 70 and 90 millimeters of mercury, just enough to perfuse organs and get him to the operating room as fast as possible.
That's exactly right. Permissive hypotension is the strategy. Prioritize rapid transfer and surgical control over aggressive fluid resuscitation in this critical preoperative phase.
Right. Now, assuming the patient makes it through the repair, whether it was open or endovascular, what are the potential complications we need to watch out for afterwards?
Post-treatment care and managing complications are obviously vital parts of the process. Especially after EVAR, one of the primary concerns is the development of endoleaks.
Endoleaks, can you break down what those are?
Sure. An endoleak is basically persistent blood flow into the original aneurysm sac outside of the stent graft. The graft is meant to exclude the sac, so flow outside it is abnormal. They're classified into different types based on the source of the flow.
Okay, what are the types?
Type 1 endoleaks involve an incomplete seal at either the top proximal or bottom distal end of the stent graft. Blood leaks around the end of the graft into the sac.
That sounds bad.
It is. Type 1 leaks are critical because they mean the aneurysm sac is still pressurized by direct aortic blood flow, carrying the same risk of rupture as before the repair. They require prompt treatment.
Okay, type 1 needs urgent attention. What's type 2?
Type 2 endoleaks are actually the most common type. These occur when blood flows backwards into the aneurysm sac from branch arteries that originate within the sac area, like lumbar arteries or the inferior mesenteric artery, which weren't covered by the graft.
So blood feeding back into the sac from side branches.
Exactly. The interesting thing about type 2 endoleaks is that many, perhaps at least 50%, resolve spontaneously over time as those feeding vessels thrombose or clot off.
So do they always need treatment?
Not necessarily. Treatment for type 2 endoleaks is generally only indicated if they persist and the aneurysm sac shows significant expansion on follow-up imaging, usually defined as growing more than 5 to 10 millimeters in diameter, or if the patient develops symptoms related to it.
Okay, watchful waiting unless the sac grows. What about type 3?
Type 3 endoleaks are due to a failure of the graft itself, either an incomplete seal between modular components of the stent graft system, or rarely erosion or tears in the graft fabric. Like type 1, these also directly repressurize the sac and require treatment.
Also critical, like type 1 for type 4.
Type 4 endoleaks are related to the porosity of the graft fabric itself, often seen very early after implantation as a faint blush of contrast. These are typically self-limited as the pore seal, and they generally don't require any specific treatment.
Got it. So types 1 and 3 are bad news, need fixing. Type 2 is common, often resolves, treat if sac grows. Type 4 is usually transient.
That's a good way to summarize it. Beyond endoleaks after EV, other potential complications include device migration, where the entire stent graft shifts from its original position, often downwards. This can lead to a delayed type 1 endoleak if the seal is lost.
Great.
Limb occlusion can also occur a blockage or clot forming in one of the legs or limbs of the stent graft. This seems to be somewhat more common with endografts than with traditional sewn-in surgical grafts. And graft infection, while rare after either open or endovascular repair, is a very serious complication when it does happen. Incidence seems comparable between the two approaches.
With all these potential issues, especially after EVR, how do you monitor patients long-term?
Postoperative surveillance imaging is absolutely essential, primarily to detect these complications early and prevent late aneurysm rupture or other adverse events. The protocols differ slightly for OSR and EVAR.
How so?
After open surgical repair, the main concern is development of new aneurysms elsewhere or dilation next to the graft. Guidelines generally recommend abdominal and pelvic CT imaging about every 5 years.
Every 5 years for open repair.
Right. For EVAR, because of the specific risks of endoleaks, migration, and sac changes, the surveillance is more intensive, especially early on. The standard initial protocol usually involves a CT scan at 1 month post-op, then again at 6 months and 12 months.
Okay, more frequent early on.
Yes. And then yearly CT scans thereafter. However, there's a caveat. If the 1-year CT scan shows a stable or shrinking aneurysm sac and no endoleak is present, subsequent yearly surveillance can often be safely performed using duplex ultrasound instead of CT.
Switch to ultrasound later if things look good.
Exactly. It helps reduce cumulative radiation exposure for the patient while still effectively monitoring for major issues. But any new concerning finding on ultrasound, like a suspected new endoleak, evidence of graft migration, or significant aneurysm sac growth, say more than 5 or 10 millimeters, should prompt a return to CT for more detailed evaluation.
That makes sense. Use CT when needed, but default to ultrasound when stable. Are there any other key aspects of post-op management?
Just a couple of points from the guidelines worth mentioning. For perioperative management, there's a grade 1B recommendation to transfuse packed red blood cells if hemoglobin drops below 7 grams per deciliter, aiming for a restrictive transfusion strategy.
Okay, transfuse below 7.
And specifically after open surgical repair, which involves a significant incision and recovery, there's a grade 1B recommendation for using multimodality pain management, often including epidural analgesia, to optimize postoperative pain control and recovery.
Good pain control is key after open surgery. Okay, so post-op. Watch for endoleaks, types 13 critical, type 2 treat if sac grows. Migration, limb occlusion, infection. Surveillance is crucial. OSR needs CT every 5 years. EVAR needs CT at 1, 6, 12 months, then yearly CT or US if stable. Transfuse below HB7, use multimodal pain control after OSR.
Precisely.
So, looking at the big picture, we've covered a lot from definition and risks to screening, treatment, and complications. Where does research go from here? What are the next frontiers in AAA care?
That's a great question. The field is definitely not standing still. There are several key areas where more research is needed and actively ongoing.
Like what?
Well, one major area is digging deeper into the underlying biology, identifying specific genetic factors or biological pathways that predispose individuals to developing aneurysms in the first place. Understanding the why could lead to better prevention.
Finding the root causes.
Exactly. Related to that is the search for effective pharmacologic agents, medications that could actually slow down or halt the enlargement of existing small aneurysms, potentially avoiding the need for surgery altogether in some patients. That's a huge goal.
A pill to stop aneurysm growth. That would be a game changer.
It really would. Another area is improving risk stratification, finding better biomarkers, perhaps from blood tests or advanced imaging analysis, that can more accurately predict which specific aneurysms are at highest risk of rupturing, independent of just size.
Better prediction of rupture.
Right. On the device front, research continues on developing better prosthetic grafts for open surgery and improved endovascular stent grafts, making them more resistant to infection and thrombosis, and designing new grafts that can treat patients with more challenging aortic anatomy, like highly angled necks or involvement of branch arteries, which can be difficult for current devices.
Expanding who can be treated with EVAR.
Yes. And finding more reliable, durable, and cost-effective ways to treat those problematic endoleaks, particularly type 1 and persistent type 2 endoleaks, remains a significant challenge and focus of innovation.
So, genetics, drugs, biomarkers, better devices, better endoleak treatments, quite a lot on the horizon.
Absolutely. And all of this needs to be framed within the context of delivering cost-effective care, ensuring that these advances provide real value to patients and the healthcare system.
This has been incredibly informative. We've really journeyed through the complexities of abdominal aortic aneurysms, understanding what they are, the critical risk factors like age and especially smoking, the life-saving potential of screening, the evolution from open to endovascular repair with their respective pros and cons, and the importance of managing complications and ongoing surveillance.
It's a field that has seen remarkable progress, particularly with the decline in smoking and the advent of EVA-R significantly reducing rupture mortality. But, as we've touched upon, challenges remain. Accurately identifying every individual at high risk before rupture, tailoring treatment perfectly to each patient's anatomy and overall health, and managing those long-term complications effectively. These continue to push the boundaries. Which leads to perhaps a final thought for our listeners to consider.
Okay.
How might the convergence of what we're learning in genetics, the power of advanced imaging techniques going beyond simple diameter, and the potential development of novel pharmacotherapies truly reshape how we manage abdominal aortic aneurysms in the next decade? Could we reach a point where rupture becomes an even rarer event and interventions become even more targeted and less invasive?
That's a powerful vision for the future. Thank you for that deep dive. If this discussion sparked your interest, we encourage you to share it or delve deeper into vascular health resources. Understanding these conditions truly makes a difference.